Welcome, everyone. I'm Dick Deming. I'm Medical Director of Mercy One Cancer Center, and I'm the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. This series is brought to you in part by a grant from the Iowa Oncology Society. And our topic tonight is colorectal cancer, and our guest is Dr. Durado Brooks. Dr. Brooks, welcome.
Hi there. Thanks for having me.
Thank you for being here. Dr. Brooks is Associate Chief Medical Officer for the Cancer Screening Unit for Exact Sciences Corporation. And as I mentioned, he's a medical doctor, internal medicine physician, and also has a master's in public health. So before we talk about colorectal cancer, let's learn a little bit about you, Dr. Brooks. Where are you from originally?
Sure. I grew up in Columbus, Ohio, and went to Ohio State University undergrad.
What was
So
your major what was your very first major when you started college?
my very first major was social sciences, actually, and I stuck with it. I knew I wanted to go to med school, but I also wanted to kind of understand people. So there was a lot of psychology and sociology and, getting a feel for populations. Did not realize I was going to end up going into population health, but it was helpful.
Right. So, but you had to mix all of those social sciences with enough of the hard sciences in order to have your prerequisites for
Exactly.
for
Yes.
medical school.
Yes. Or organic chemistry in particular was quite a bugaboo, and little biochem and um, a number of those hard sciences. So actually, the social science was a nice balancer
Yeah.
for life.
Yeah. It's ironic because I think those of us not in the laboratory, but that are taking care of real patients and families, I think the humanities and the social sciences probably give us more tools to deal with that communication piece. Yes, you've got to have the hard sciences, but I use much more of my speech and theater and poetry and theology and religion in the hard conversations than I do drawing organic chemistry models.
Yeah, yeah. I could not draw a organic chemistry a chemical model to save my life right now. So fortunately, that's one of those things that you need to know and understand in order to move forward, but it's not something that has to stick in your brain for the next 30, 40 years.
So the Ohio State for undergrad, and then where did you go to medical school?
I went to Wright State University, which is also in Ohio. It's down the road in Dayton. And the appeal of Wright State for me actually was that, unlike the other major medical schools, Ohio State and Cincinnati, where I also had the opportunity to go, at Wright State, they were very focused on family medicine. And I believed that I was going to go into family medicine at that time.
Mhm.
And we began seeing patients our first week in medical school.
Oh,
Um,
wow.
actually started going to clinics and seeing patients under supervision, obviously, but the idea of really getting to interact with people in that way from the very beginning held tremendous appeal.
And then you graduated from medical school and went into internal medicine for your residency. And where did you do your internal medicine residency?
I actually stayed right there in Dayton and did my internal medicine residency at Wright State. And then, similar to you, I had an obligation. You had the military obligation. I had an obligation to the National Health Service Corps because I had gone through medical school on a scholarship from the
Mhm.
NHSC, which required that I work in underserved environments after graduating from medical school. Since that was my plan all along, it was a perfect fit. So I was able to complete my residency there in Dayton and then had the good fortune to match at one of the hospitals there in their neighborhood clinic and worked in that neighborhood clinic system for a couple of years beyond my residency, practicing general internal medicine.
And then somewhere along your career, you also went back to school or picked it up while you were working this Masters of Public Health, MPH.
Yes, that was a little later. I actually left Dayton and moved to Dallas, Texas, and went to work for Parkland Hospital, the county hospital system in Dallas. again, focused on vulnerable populations and underserved populations, and worked in that system for a number of years. And then, as I'm sure, you recognize and may have experienced when you're in medical school and in residency, you learn a lot about practicing medicine, but you don't learn much about the business of medicine, about the policy structure of medicine, in trying to take care of vulnerable populations. I kept running into roadblocks and barriers that I had no idea how to get around. And that frustration ultimately led me to look for a place where I could learn more about health policy. And there was a program at the Harvard School of Public Health that was designed for clinicians working in vulnerable environments who wanted to learn more about health policy and how to impact systems at a higher level. So I was fortunate to place into that program, and part of that program was working on a master's in public health. So um,
Right.
helped shift my focus from the individual patient level to thinking about population health. How do you address the health of hundreds of thousands or millions of people, as opposed to just those patients that you're seeing in your office every day? And then I after finishing that program, had just the incredible good luck to start a position at the American Cancer Society. So it was the perfect place to blend my prior experience in primary care medicine and clinical medicine with this newfound focus and interest in population health. And I mean, that's what the American Cancer Society is all about. It's about trying to change the trajectory of cancer for everybody across the country and really across the world.
Yes, and I had been a volunteer for the American Cancer Society, and actually had the honor of serving as chair of the board for the American Cancer Society Cancer Action Network.
Okay.
And as you know, as doctors, one patient at a time, we can try to help reduce the barrier of cancer. But when we get involved in policy debates and decisions, we can change the the scope of care for millions of individuals. And
Exactly.
I think kind of the lead that the American Cancer Society took with advocating for the Affordable Care Act, and you know just access to healthcare. It doesn't matter how many fancy expensive pills you have if the people you're taking care of can't afford those pills. So learning all about, which is your bread and butter, the social determinants of health, and how do you take care of a population? Number one, recognizing all the barriers that lead to higher incidence and worse outcome, and how can you systematically make changes in policy to to help folks, not just invent a new drug that they don't have access to.
Exactly. Yeah, and the American Cancer Society has really been at the forefront of the access issue, as you mentioned. When the organization came out in support of the Affordable Care Act, there was a frankly unpopular position with a significant number of their volunteers, the clinicians who had worked with them, as well as business people. But they simply knew that it was the right thing to do. It was the necessary thing to do if we were really going to make changes in the health policy landscape and the healthcare landscape for individuals who were uninsured. And and following the passage and implementation of the Affordable Care Act, lack of insurance plummeted relative to prior to ACA. And even with all the headaches, challenges that it has faced over the subsequent now, 12, 11, 12 years, we still have strikingly lower rates of uninsured people. And there's a fair amount of data, as I'm sure you're aware, demonstrating that in those states where they fully implemented the Affordable Care Act, including in their Medicaid population, there are lower death rates from cancers in those
Mhm.
states and those populations. So it is it was one of the things I was proudest of being involved with the ACS when they decided to take that unpopular measure because it was the right thing to do.
Yeah. And you're talking about lowering death rate, and really, we're going to switch now to talking about colorectal cancer and screening in particular. But that's the whole goal of screening. Screening with the exception of colonoscopies that might actually decrease the incidence of cancer, for the most part, screening means finding cancers at an earlier stage where the opportunity to cure the cancer is better. And that's primarily why we do screening.
Exactly.
Um,
And in addition to colorectal, the other place obviously is cervical cancer screening. And what we did with pap smears in the past and are now doing with HPV testing is again helping identify lesions that aren't cancer that may progress to cancer. And if you find those lesions and you're able to address them, remove them in the case of polyps in the colon, or address them in other ways, in the case of cervical lesions, you can actually prevent cancer from occurring. And that's one of the big things that has really um, frustrated but also motivated me in working in the colorectal cancer space. Cancer screening overall, breast cancer screening, prostate cancer screening, lung cancer screening, all of those are important. But the fact that you can actually change the course of disease and prevent cancer from occurring through screening for colorectal cancer, in my mind, gives it um, a measure of relevance that I think is often missed by the public and unfortunately by a lot of primary care providers.
Yeah. So let's talk about colorectal cancer. It's March, it's Colorectal Cancer Awareness Month. And tell us a little bit about the significance of colorectal cancer as a burden, as a significant cancer that we see in the United States. Maybe share with us some of the incidence and mortality figures.
Well, this year in the US, we expect to see over 150,000 new cases of colorectal cancer. It's largely an equal opportunity killer in that it attacks both men and women. Um, there will also be about 53,000 men and women who die from colorectal cancer in the US. Now, the good news is that both the incidence and the death rates have been falling pretty steadily in the 50 plus population over the last 2.5, 3 decades. And that corresponds pretty closely with when we started doing screening actively and aggressively in the US. So, as screening rates have risen, you've seen the curves for death and cases going down steadily. Um, but as I mentioned, there's an age cutoff for that. And what we have seen, unfortunately, is also a slow but steady increase in colorectal cancer in younger individuals, particularly in people under the age of 50. Because for more than 20 years, it was recommended by the ACS and other major organizations that screening should start for everyone beginning at age 50, unless you had a family history or other things that necessitated earlier screening. But looking at those trends while I was with the American Cancer Society, we looked at those trends and actually made a change in those recommendations back in 2018 and began recommending that all average risk people start screening at the age of 45 because of the rising rates we were seeing in people under age 50. And ACS was the first and stood alone out there for a couple of years, but then other organizations came along, and as of now, just about every major medical organization that has guidelines for colorectal cancer screening recommends starting at age 45. So 45 has become the new 50 because of these unexplained rises that we're seeing
Mhm.
in younger individuals.
What are some of the risk factors that make individuals more likely to develop colorectal cancer?
There are a number of different things. One is simply not getting screened. That's a behavioral risk factor. That's one that you can control entirely. There are other behavioral risk factors, things like cigarette smoking, that increase risk. Diet, particularly diets that are high in fat, high in red meats, low in fruits and vegetables, increase the risk for colorectal cancer. And then there are a variety of things that you can't really control, like your family history. If you have a family history of colorectal cancer, particularly in a first degree relative, mom, dad, sister, brother, your risk is dramatically higher. As a matter of fact, if one of your family members has had colorectal cancer or even had one of those precancerous polyps that I talked about earlier, your risk is high enough that you need to start screening at an earlier age. And what age you need to start screening depends on how old your relative was when they were diagnosed. But in most instances, at the latest, you would start screening by age 40. Um,
And Dr. Brooks, I went to medical school at Creighton, so one of my
ah,
professors was Dr. Henry
and
Lynch.
yes,
Why don't you tell us about Lynch syndrome and the genetic predisposition to colorectal cancer that comes with that?
yeah, there are a couple of different family history approaches to colorectal cancer. In most instances, there's a family history, but not any clear cut genetic um, defect or change in your genes that we can identify and say, okay, you're at higher risk of developing colorectal cancer. That's that general mom, dad, sister, brother. But then there are families that have specific genetic changes that have been associated or are known to be associated with colorectal cancer, and in many instances, like the Lynch syndrome, with a variety of other cancers. So it's really important. If you have a number of different types of cancer in your family, you need to talk with your doctor and have them basically do a family tree and outline who had what type of cancer and at what age those cancers were diagnosed, because that might point your doctor toward doing some sort of genetic testing to assess whether or not you have uh, Lynch or one of the other uh, gene syndromes that can be associated with colorectal cancer or other kinds of cancer risk.
Yeah, and we have a genetic counselor at our center as well, and um, I think that statistics are about 10% of individuals' cancer can be attributable to a genetic mutation that you might have inherited from mom or dad. You mentioned some of the other risk factors, including cigarette smoking, diet. A couple of others that kind of fit in there also are the lack of physical activity, and obesity also increases the risk of colorectal cancer. There was a story just yesterday on the National Public Radio featured it. It was an article in the British medical journal called Lancet, where they looked at ultra processed foods.
Hmm.
So these would be things that are, crackers and cookies and anything that comes in a package, and that in the American diet, about 50%, the average American consumes almost 50% of their calories from ultra processed foods. And the relationship between a number of chronic health conditions, including anxiety, depression, diabetes, obesity, metabolic syndrome, and cancer, in particular colorectal cancer, are attributed or are associated with eating more of your calories from these ultra processed foods.
Well, I mentioned that we've seen this rise in colorectal cancer in younger individuals, and diet is suspected to be at least one of the potential causes associated with it. Obesity being another. We see much higher rates of obesity across the population and in younger individuals now than we did looking back 30 to 35 years ago. But the changes in diet also are very important, and there's a lot of work going on trying to pinpoint exactly what it is that's contributing to these higher rates. But diet is a very highly um, um, sought after suspect.
So I'm going to ask you to put on your public health hat again. So I know in many types of cancers, in particular, breast cancer just stands out that the mortality rate for African Americans is significantly worse, stage for stage, than the Caucasian population. Does the same hold true for colorectal cancer?
Unfortunately, it does. And so, even for individuals who have their cancers diagnosed at the same stage of disease, The survival rates for African Americans or the Black population in the US are significantly lower than for the white population. The reasons behind that are complex and not completely understood, but some of it has to do with access to care and access to high quality care. There are a number of different studies that have looked at whether or not individuals who are diagnosed with cancer get what's called state of the art care. That is, the highest level of evidence that's demonstrated that this type of radiation treatment, this kind of chemo, this surgical approach can have a positive impact on cancer outcomes. And in study after study, it's been shown that African Americans and other minority populations have a lower likelihood of getting that kind of state of the art care. Whether or not there are also, some genetic or other factors that figure into those higher rates of mortality aren't clear, but we do know that, and simply access to healthcare in general, as we were talking about a little while ago, the not everybody who gets cancer, not everybody who's diagnosed is going to be able to come to a high quality cancer center, for instance, and get their treatment from individuals who are trained in the latest techniques. And not having access to care or high quality care is a big contributor to some of the disparities that we see.
Okay. So let's talk about screening for colorectal cancer. And screening is testing individuals who might be at risk for having cancer but don't have symptoms. So, just to remind our audience, if somebody has blood in their stools or abdominal pain or difficulty with defecation and goes in and gets a scan or gets a colonoscopy, that's not a screening. That's actually working up symptoms. So screening means you don't have symptoms, and there are several different validated ways of screening a non-symptomatic person for colorectal cancer. Dr. Brooks, can you share with us the various methods of screening for colorectal cancer?
Yeah, certainly. And I really appreciate you emphasizing the importance of the lack of symptoms because, in many times, when you're talking with patients or non patients, the general public, their perception is, oh, my bowels move fine. I don't see any blood. I don't need to worry about this. Screening is something that we do in advance of any symptoms. It's something we do when we don't suspect that you have disease. We're doing it because you are of the age or you've got the risk profile, like a family history that indicates you're at higher risk of developing disease. And our hope is to find something before it turns into cancer. And if not, to find cancer in its earliest stages. One of the things about two things about colorectal cancer. One is the fact that it can be entirely prevented by the screening test that I'm going to talk about, because we can find polyps, which are abnormal growths that are not cancer, but can progress and turn into cancer. If we find those polyps and remove them, we prevent cancer from occurring. The second thing is, even if we miss that opportunity to prevent cancer, if we screen you and find your cancer in the earliest stage, when it is still stage 1 or stage 2, has not penetrated through the colon wall or started spreading to other parts of the body, 9 out of 10 people are going to be alive 5 years later. 91% 5-year survival for individuals who are diagnosed with early stage colorectal cancer. So it makes a
Right.
tremendous.
And the treatment's easier too, because oftentimes a stage 1 or 2 may need just surgery and not have to have chemotherapy or radiation. So
Yes.
not only is there chances of surviving and being cured greater, but it's also usually requires much less intensive treatment.
Exactly. With regard to how we screen, there are a variety of different options, and that's really important to keep in mind. Whenever I talk about colorectal cancer screening to the general public, the vast majority of people, their mind will go immediately, oh, I need a colonoscopy. Colonoscopy is a great tool, but colonoscopy is not the only tool. And there are a variety of reasons that people either don't want or don't have access to colonoscopy. So while colonoscopy certainly should be on your list if you have access, it shouldn't be the only thing that's on your list. There are what are there are two broad categories. There are what are called direct visualization exams, and colonoscopy is one of those, where a tube is inserted into the rectum, a lighted tube with a camera on the end, and it looks at directly at the lining of the colon. That's why it's called direct visualization. There is another exam called a flexible sigmoidoscopy, similar to with a camera but shorter, and it only looks at about the lower third of the colon. That really is utilized very little in the United States anymore, since colonoscopy has become so widely available. But it is still included in guidelines. And then the third direct visualization tool is what's called virtual colonoscopy, or CT colonography. And that's basically a CAT scan of the abdomen done in a special way that looks, again, at the lining of the colon. So all of those are included in the guidelines. All of them have potential benefits and limitations associated with them, but all of them are effective ways to get screened.
And
Um,
swallowing the camera, is that a form? Is that considered direct visualization?
It is, but it is currently not included in any of the guidelines. The evidence for using the pill cam to screen for colorectal cancer is growing, but still very limited compared to the evidence we have for the other kinds of tests.
Gotcha.
So it is really recommended only in very limited circumstances as a screening test for colorectal
Yeah.
cancer right
And so for those who don't know, you actually swallow a pill that has a camera in it, and it does a video of everything as it goes through your digestive system, from the esophagus into the stomach, into the small intestine, into the large intestine, into the rectum, and then it's retrieved in the stool. And that is something that the technology exists, but trying to determine whether it's as effective at discovering early cancers as the other direct visualization. It sounds like we don't have direct evidence that it's as good as the other forms of direct visualization.
now. Exactly. There's a lot of work going on looking at, again, as I mentioned earlier, there are a lot of people who either can't get or don't want a colonoscopy. So trying to find alternatives to colonoscopy has been something going on for the last 20 years. Um, Beyond the direct visualization exam, the other kinds of tests that are tests that look for either hidden blood in the stool. They're what are called guaiac test or fecal immunochemical test, which look for small amounts of blood, not blood that you would see actively on the tissue or see in the toilet bowl, but tiny little amounts that would not be visible to the naked eye, but can still be there and indicate the potential for something that's bleeding, either a polyp or a cancer. Or the other type of stool test is the test made by the company that I work for, Exact Sciences, and we make a test called Cologuard. And if you ever watch, traditional TV, there's a good chance that you've seen our little talking Cologuard box telling people about getting screened for colorectal cancer starting at age 45. And Cologuard is a test that includes looking for hidden blood, but also looks for DNA changes, altered DNA that is present in the stool that can indicate the presence of either a polyp or cancer just by doing a stool specimen. So stool
And
test.
Dr. Brooks, that the genetic part, that's just to clarify, that's looking for cell-free DNA from colon cancer cells. That's what
Yes,
it's picking up?
whenever people pass a stool, in that stool, there are cells from the lining of the colon that are excreted along with the other waste material. And the Cologuard test has found a way essentially to look at the materials from those cells. Once they break down as they're being excreted, and look for DNA changes that are known to be associated with cancer in the mix of that waste material and that cellular waste.
Yeah. It's just amazing, the technology that we were able to find little bits of cancer DNA in the stool.
Literally needle in a haystack.
Hmm.
But it's been demonstrated to be highly effective at finding those needles.
And I just want to highlight something you say, and then ask something that you said, and then ask you to go into more detail. So, various. We went through the various ways of looking at the inside of the colon, and now we're talking about various ways of examining the stool, the feces.
Right.
And one type of test just looks for blood. So, are there red blood cells in this stool that could indicate that there was a source of bleeding? And then the second one you talked about is the Cologuard looks for the blood, but then it does a separate test looking for DNA from cancer cells in the stool.
Exactly. Cancer or precancers.
Prancer, okay.
Yes.
And the results, so on the blood tests you get either yes there's blood or no they didn't detect blood. What type of a readout do you get with the Cologuard where they're looking for two different things, both the blood and the cancer DNA?
It's actually a single yes or no, positive or negative result based on the combination. Each of the different things that we're looking for, there are 10 different DNA markers that our current on market test looks for, as well as the hemoglobin marker. And each of those is given a score based on, how much of that material was present, or obviously zero if none of that is present. And those scores are then added up and plugged into an algorithm, and that algorithm comes out with a single score. And if the score is over 183, then it signifies there is a higher potential that you have a polyp or a cancer in your colon. If the score is less than that, then there's a very low chance that you have a polyp or cancer in the colon. Now,
So if
with
you
all the
do,
blood tests, either if there is positive blood in the fecal immunochemical test or the guaiac, or if there's a positive finding on the Cologuard, it is essential that that patient now undergo colonoscopy. That's the only way to determine what caused that positive finding.
gotcha.
The good news is that in most instances, it will not turn out to be cancer. The many more of those folks who have a positive finding are found to have precancerous polyps or other abnormalities in the colon, then are found to have cancer. But the only way to make sure that cancer is not present is to do that colonoscopy.
Right. But for those individuals where the stool is tested and you don't find blood and you don't find DNA, then you don't have to have a colonoscopy.
Correct. But you do need to get screened again on a regular basis.
Yes.
I didn't talk about the interval, but for colonoscopy, for instance, if you have what's called a high quality colonoscopy, one of the challenges with colonoscopy, unfortunately, is not every doctor who does colonoscopy is really good at it. And over the last decade, there have been a number of different of scoring measures that have been developed to help determine how good or not good a particular provider is. So it's important that when if you're going to get a colonoscopy, you should ask your doctor to ask whoever's going to be doing that exam about their quality measures and how well they're doing with things like finding adenomas and other kind of measures. But if you have a high quality colonoscopy and nothing is found, you don't need to get screened again for 10 years. Um, that's because that they've looked directly at the lining of your colon, and the likelihood of you having a polyp or a cancer is very, very low. With blood test, stool tests that look for blood, like the fecal immunochemical test, that test is going to miss a significant number of both polyps and cancers, and therefore it needs to be repeated every year. The Cologuard test is kind of intermediate. It does a much better job at finding polyps and cancers than the fecal immunochemical test in the studies that we've done. But it does not find as many as colonoscopy. Consequently, the Cologuard test, if it is negative, needs to be repeated every 3 years. So depending on which test you choose, your next screening interval is going to be based on that.
Right. So thanks for clarifying that. And it's one of the reasons that it is so confusing. And, cancer doctors in general aren't the doctors that are doing the screening, because screening is typically done on people who don't have cancer. And so, trying to keep track of all the various ways of screening and the different intervals in which it needs to be done. At my institution, we're having a difficult time just saying how many of our patients are up to date on screening, because the screening is three different things and different intervals, and even knowing, okay, is this patient due for screening now or not? We're hoping, as we get unified electronic medical records that are good at keeping track of these things for us, that we'll be able to make sure that we're more thorough at making sure everyone gets the screening at the right interval.
Yes, absolutely. And it really, though, is incumbent on the patients and family members, honestly, to keep up with screening and who needs to be screened, when you need to get started. Getting into the system and actually getting started screening, I think, is the key measure. And the closer to 45 you are when you start getting screened, the greater the likelihood that that screening is going to help prevent cancer or find it very early for you over the course of your lifetime. People who delay screening for a long time, oftentimes it's one of those things that, well, I'll get to it, and then they just don't get to it until they start having symptoms, or until their doctor sees something abnormal in their blood test. And oftentimes in those cases, we're looking that's when they're having to come and see you to treat something that might have been prevented early on. Even I've learned patients who have family members who have colorectal cancer oftentimes will put the blinders on and not want to get tested and evaluated. And I cannot emphasize, I know that many in your audience are folks who either dealt with cancer themselves or have family members. I cannot emphasize strongly enough how important it is to get screened, because preventing cancer is so much easier than treating it. And treating early stage disease, as you pointed out earlier, is so much easier than dealing with these disease that has started to spread.
You made another point that I think it deserves repeating. And so, screening, everyone's familiar with mammograms, and mammograms is a very good screening technique for breast cancer. And it's definitely been shown that women who get screened are more likely to find their cancer at an earlier stage, and it leads to a lower death rate. But getting mammograms does not prevent cancer. Um, just maybe go over again the value of colonoscopies, not only to find cancer, but to actually prevent cancer. How does undergoing colonoscopy actually prevent cancer?
It, by finding and removing precancers. There are really only two cancers, two common cancers in the US where we have lesions that indicate that cancer may be coming and may occur in the future because they may progress. And that's with cervical cancer for women getting pap smears or now getting HPV testing, or for colorectal cancer. In the case of colorectal cancer, there are little growths in the colon called polyps. And those polyps, most polyps will never turn into cancer, but there are certain types that when we see them, we know they're at higher risk of progressing. Unfortunately, people with polyps have no symptoms whatsoever, and those polyps can be there for years. They may bleed, but if they bleed, they're going to bleed intermittently. And if you don't get tested, that polyp is going to stay there. And over time, every year, the longer it's there, the greater the chance that it is now going to progress and ultimately lead to cancer. Even in the early stages of cancer, in many instances, people have no symptoms whatsoever. I'm sure that, in your practice, as in mine, you see a number of patients who will suddenly show up and they're having some blood in their stool or having a little abdominal pain, or maybe they've just started losing weight, and then you evaluate them and find that they've got large or invasive cancer growths that they and you had no indication might be there until very recently. So waiting for symptoms to develop is waiting for cancer to grow and spread.
Um, there's one other type of screening that is being researched, and just this last week, there was a article in the New England Journal of Medicine, a blood test specifically to find circulating tumor DNA from colorectal cancer cells in the bloodstream. So you actually take a sample of blood and can look and find circulating tumor DNA from colorectal cancer cells in the bloodstream. And for those who watch our show on a regular basis, last week we talked about the multi-cancer early detection blood test. So a blood test that can detect up to 50 different cancers by looking for circulating tumor DNA from cancer cells in the bloodstream, and colorectal cancer is one of them. This science is so exciting. Right now, it's not FDA approved to demonstrate that doing these tests lead to a reduction in death rate, but there's a lot of excitement, and I think most of the scientific community, including the American Cancer Society, thinks that these are going to turn out to play a role in screening of colorectal cancer. Do you have anything else to add about that technology of finding cell-free DNA from cancer cells circulating in the bloodstream?
Well, again, your audience, or at least some of them, heard about the multi-cancer early detection test just last week, and it is an incredibly exciting new technology. Looking for single organ cancers like colorectal cancer is very similar kinds of technology. The blood test, I think all of us in the cancer screening world think that it is going to have a role. The question is exactly what that role is going to be. As with any new technology, I mentioned that, colonoscopy only needs to be repeated every 10 years because it looks directly at the lining of the colon, and the likelihood of missing polyps or cancers is much, much lower than with other screening tests. The blood test, the concerns are how many abnormalities we might miss. The blood test that was reported in the New England Journal actually had reported very high sensitivity for cancer. It found about 9 out of 10 cancers that were present in the patients who went through the study. But where it missed was the precancers, those polyps that I talked about. I only found about 13% of those. So nearly 9 out of 10 people who had polyps that would be considered significant in that study had no evidence of that based on the blood test results. And that has unfortunately been a common picture in other blood tests that have shown up in the medical literature. So there are any number of people who may strongly prefer a blood test and are just, again, unwilling or unable to do colonoscopy, or unwilling or unable to do stool collections. For folks who, for one reason or another, don't want or can't use the current state of the art test, the blood test may be a good alternative, but it's going to be important for people and for their clinicians to understand what they're giving up if they choose to use a blood test as opposed to one of the existing guideline associated tests. And guidelines are important. I mean, that's one of the things about all of the tests that I talked about, is they've all been evaluated by multiple major medical organizations looking at all of the evidence about their ability to either prevent colorectal cancer or find it early. And the 5 approaches that I discussed are included and recommended in guidelines. Right now, there's just not enough evidence around blood tests, and no guidelines are currently including it.
And as you have reminded us in other talks that I've had the opportunity to listen to you, the best validated screening test is the one the patient will do.
Yeah, absolutely. Yes.
So let's open it up for questions. So we've got a live studio audience here. We also have individuals that are watching us live streaming. If you're watching us live streaming, please put your question in the comments section. And we'll start with our live studio audience here.
I've got a question. We all hear about the polyps. Exactly what are polyps? Why are some precancerous? Why are some cancerous? And are they always there? Or to talk about polyps?
Okay, really good question. Many people are familiar with skin tags, where, for instance, under your arm, you'll suddenly find a little lump of tissue, and over years, you might notice that it's growing more. And um, people oftentimes will go see a dermatologist, get it shaved off. Well, a polyp is somewhat similar to that. It's an abnormal growth of cells that, for unexplained reasons, in most cases, will just start growing along in the lining of the colon. Most of them, as I mentioned earlier, don't really have any tremendous cancer potential. It's just that the body, it keeps track of so many different things, and sometimes it lets a few cells that aren't dangerous start growing in an uncontrolled way. But cancer is when the wrong kinds of cells start growing in uncontrolled ways. And those polyps that start out as non concerning in some instances over time will progress to the kinds of polyps that can grow into cancer.
And what percentage of patients are being screened get the so-called the 10-year pass? Is that percentage going up or down?
That's another really interesting question, and I would say that the percentage is probably going down in a lot of places, but it's not going down necessarily because there are more polyps. It's going down because there are more polyps being found. I mentioned that over the last 10 to 15 years, there's been a greater emphasis by the gastroenterology community on higher quality colonoscopy and quality measures. And as these sort of measures have come into play, more and more polyps are being found. There also has been improvements in the technology around endoscopes, for instance, and how colonoscopies are done. So more polyps are being found than were being found 15 years ago. Probably a similar number of polyps were existing there 12 or 15 years ago, but they weren't being seen and removed the way that they are now.
So the good news is more cancers are being prevented. The bad news is when they do find polyps, then you can't wait 10 years for your next colonoscopy. So you have to have it a bit more frequently.
Yeah. And your question, I neglected to answer one part. About 7 out of 10 people undergoing a high quality colonoscopy won't have any abnormalities found and will get that 10-year pass that you mentioned. But about in high quality settings, about 30%, somewhere between 25 and 35%, or 25 and 30% of people will have at least one significant polyp found and therefore need to get screened again, usually in a 3-year window.
3 years. Okay. Another question,
Yes,
Kevin?
Yes, I have friends who have aged out of the colonoscopy schedules. So, what's the experience of that population who it's no longer relevant to them?
That's another great question. Your audience is on top of things, aren't they?
They are very sharp.
Yes, yes. The guidelines currently recommend screening for individuals between the ages of 45 and 75. After the age of 75, each of the guidelines, if you look at the language, it essentially says for people over 75, you need to make an individual decision now, which means, has this person been screened regularly? If you start screening regularly at 45 or 50, you've had multiple screening exams and never had any abnormalities detected, the likelihood that at 77, 78, that something new is going to show up is pretty low. So it would not be unreasonable to discontinue screening. On the other hand, if you were screened, once at age 45 or 50 and you haven't been screened anymore, or if you have family history, if you have relatives who've been diagnosed with colorectal cancer, or if you have a lot of risk factors, if you are obese and you smoke and you have diabetes, which I didn't mention earlier, but is actually a risk factor for colorectal cancer, then you may need to continue with a screening schedule. Whether or not that needs to continue to be colonoscopy is yet another question. If you've had a couple of completely negative colonoscopies, then considering, and you want to continue screening, then considering one of the non-invasive screens might be a consideration for you.
Thank you. We have another question.
I'm always interested about the payment and the cost of these types of things. We talked a little bit about the ACA to begin with, but the age of the necessary screening is dropping to 45. It's a long way from Medicare, and this is a life and death thing. What about paying for this outside of the ACA? I mean, shouldn't everybody be getting screened regardless of how we're getting paid for it for life and death reasons?
Yeah. Absolutely. And that was one of the things that the Affordable Care Act brought into our healthcare system, is a requirement that insurers pay for anything that has what's called an A or B recommendation, a strong recommendation from the U.S. Preventive Services Task Force, one of the major guideline bodies. And colorectal cancer does have exactly that rating. Consequently, if you have insurance that is under the mantle of the Affordable Care Act, which is about 90% of insurance in the US right now, it is required that you be able to get any of the screening tests I've talked about, up to and including colonoscopy, with no out-of-pocket costs. You shouldn't have any copays or deductibles associated with that. So that's been one of the biggest advances for healthcare coverage and screening coverage in particular in our history of having insurance. When I started doing this work 25 years ago, Medicare didn't even cover colonoscopies for screening. So now the fact that we have such broad coverage is encouraging. There also was an issue for a number of years where if an individual chose to have a stool test as their initial screening test, and that stool test was positive, and they now needed a colonoscopy, as we've talked about, to make sure that what was causing that positive stool test, they might experience cost sharing, have to pay a copay or deductible for that. That policy changed about a year and a half ago. And consequently now individuals who have a stool test and an abnormal finding should not have any out-of-pocket cost. Now, unfortunately, there are holes in our insurance system. So there are still a number of folks who get bills for screening tests for which they really shouldn't get any bills. And I'm a big believer in healthcare reform and maintaining the Affordable Care Act and potentially even expanding coverage under the Affordable Care Act, because I think that that's done more for cancer screening than probably anything that Dr. Deming or me or the American Cancer Society or anybody else has done. You've got to give people access if you really want them to follow through on any of these recommendations.
Great point. And here's a question that we have from one of our live streaming guests. When screened, do the number of polyps determine when the next screening would take place?
Absolutely. Both the number and the types of polyps. Again, there are, even for those polyps that we know progress to cancer, there are still different grades, and there are some that have low likelihood of progression. If you have one or two of those, and that's all that's found during that colonoscopy, you may not even have a follow-up recommended for 5 years. For many individuals who have, 2 or 3 small to mid-sized lesions, a 3-year follow-up is going to be recommended. If a multitude, if there are a lot of different polyps found, well, one, that may trigger a more aggressive approach to make sure that you don't have one of the genetic syndromes that could be associated with colorectal cancer. And if there are a large number of polyps of a certain type, then you may even need to have a follow-up colonoscopy a year later to make sure that they haven't recurred or you haven't grown anything new or different or concerning. So yeah, both the number and the type of polyp determines when that next follow-up needs to take place.
Great. Any other questions from our audience here, either here in the room or live streaming? Well, this has been great. Thank you, Dr. Brooks. Again, our guest tonight has been Dr. Durado Brooks. He is the Associate Chief Medical Officer for the Cancer Screening Unit of Exact Sciences, an internal medicine physician, and also a public health professional. Thank you so much for being our guest.
Well, again, thanks for having me, and I really enjoyed it and enjoyed your audience.
And for those of you watching, if you know someone that would benefit by watching this video podcast, it will be available on demand beginning tomorrow at the Above and Beyond Cancer YouTube channel and also at the Mercy Cancer Center website. I hope you'll join us again next week for our cancer education series. Thanks, everyone.